Welcome to this video surgery in which we will treat a patient who has a huge atrophy in the posterior maxilla. And in this case we will use a combined technique, vertical ridge augmentation for supracrestal regeneration and sinus lift elevation at the same time. In a second stage we will place the implants after a period of healing of about 7 to 8 months. We can see here in the Conbeam CT the defect in the left portion of the posterior maxilla of this patient. The patient lost the first, second premolar, first and second molar, and you see there are two big residual defects and the amount of bone is close to zero. We have also a little bit of pathology in the sinus, but which is not really preventing our surgery because it was probably due to the presence of the teeth, and so we will manage that during the surgery. You see also here in the 3D reconstruction the shape of the defect. We see here in the cross-sectional reconstruction that we have really a little amount of bone left here. Here is almost completely absent. We have kind of a cyst here. We will check if there is some fluid inside. And here we have a very thin bone, so we have to make really a 3D reconstruction, horizontal, vertical, in a supracrestal direction, and also we have to fill up part of the sinus to make a sinus elevation in an apical direction. Okay, now we start with the anesthesia at the level of the canine. We have to go very deeply. You see here the needle is completely inside the tissues because we want to make anesthesia very deeply and apically, because we have to elevate very much apically the flap, because we want to have access for the design of the window in the sinus, and we have also to have room to place a membrane or titanium reinforced membrane in a supracrestal position. You see here I'm designing the flap. There is a vertical releasing incision that we will make here, very tiny papilla here. Then we will go intrasulcularly at the level of the canine, and then a crestal incision in the middle of the keratinized mucosa. There is a cleft here, we have to be careful, and we have to split the keratinized mucosa into portions. This cleft must be considered very carefully because it could be a reason of necrosis or exposure of the flap. The probing depth here is about 3 millimeters, so it's not so bad. Okay, we start with the incision with the 15C blade. We start with the partial thickness incision. We don't want to go directly to the bone surface because the bone surface could be irregular, it could make some kind of deviation of the blade. Then we make a second incision deep down to the bone. With this second incision we really go and cut completely the periosteum down, deeply down to the bone surface.